Welcome and good afternoon, everyone, and thank you for joining us for today's guest webinar, Honoring Voices and Experiences, Complaints to Patient Ombudsman from Residents, Caregivers, and Staff about COVID-19. My name is Kathleen Edwards, and I'm the Education Manager at Family Councils Ontario. We're honored to have Cathy Fooks, Ontario's Patient Ombudsman, join us today to share a summary of insights shared during the initial wave of COVID-19 and recommendations to the healthcare system to improve resident, caregiver, and staff experiences. Before we hand the floor over to our special guest, we'd like to cover a few housekeeping items. All attendees will be muted. We'll also ask that everyone joining us mute the microphones on their end to just make sure we can hear everyone clearly without any background noise. In the interest of time, we ask that all questions be typed into the chat box located in the drop-down panel. It should be a plus sign and it should say chat, so you type it into that box. At the end of the presentation, questions will be read aloud and answered by our guest. We'll try our best to get as many answers and questions answered as possible. This presentation is being recorded and will be made accessible in the coming days on our website. So that's it for the housekeeping items. It's my pleasure to tell you a little about Cathy Fooks. So Cathy Fooks assumed the role of Ontario's Patient Ombudsman on July 13th, 2020. Prior to becoming the Patient Ombudsman, Ms. Fooks was the president and CEO of the Change Foundation. Based in Toronto, the Foundation's mission is to improve the patient and caregiver experience in Ontario. In 2018, Ms. Fooks was a special advisor to the Ontario Ministry of Health to assist with the setup of the Ontario Caregiver Organization. Before leading the Change Foundation, Cathy was the founding executive director of the Health Council of Canada, where she was responsible for implementing the Council's mandate of reporting to Canadians about healthcare renewal. She has held other executive positions with the Canadian Policy Research Networks, the College of Physicians and Surgeons of Ontario, and the Institute for Clinical Evaluative Sciences. She has worked for the Premier's Council on Health, Wellbeing, and Social Justice, and for 2 former ministers of health. Ms. Fooks brings with her over 30 years of experience in health policy and research, government affairs, and media relations. She has written numerous articles and reports on the Canadian healthcare system. She holds degrees in political science and economics from Trent University and a Queen's University Master of Arts degree. She has completed executive program in change management at the Rotman School of Management through the University of Toronto. She has also completed the executive program in strategic perspectives for nonprofit management at the Harvard Business School. Ms. Fooks has held board positions with the Michener Institute and the Toronto Regional Geriatric Program and is currently the board chair of HDRN, a federally funded data and research network. Ms. Fooks has been recognized as a distinguished alumni by Trent University for her contributions to Ontario's healthcare system. So now that I've introduced our guest, I will let her take over with her presentation.
Great, thank you very much, Kathleen, and thank you to everybody who's joining us this afternoon. Appreciate you taking a little bit of time out of your busy day. So I'm going to run through what we have been doing in terms of the complaints we received specific to COVID through the spring of this year, show you a little bit of the data from the report that we produced last week, and talk a little bit about our policy recommendations. Just as a reminder, what our office does is we resolve and investigate complaints about healthcare experiences. Even though we're called a patient ombudsman, the complaints can come from patients, residents, caregivers, even staff. We have jurisdiction over long-term care, public hospitals, and lane coordinated home and community care. So we don't have all bits of the system. And if your complaint is specific to a regulated health professional, it would have to go to their regulatory college. We call ourselves an office of last resort, which maybe is not the best phrasing, but what it means is that if you have a complaint with a long-term care home, a hospital, or home care, you have to try to resolve that complaint with the organization that you're complaining about first. So you have to go through a process where care was provided. And then if you're not satisfied with the result of that, you come to us. So we really try to help. Obviously, we take complaints, but we really do try to help people navigate through the healthcare system, which is not really a system. It's groups of services that sometimes don't talk to each other very much. We look for fairness in our process. So it's a fairness perspective for the complainant, but also a fairness perspective for the health organization and the system as a whole. And we have the ability to really highlight issues that not a lot of people necessarily are aware of, and share our findings with the public and with policymakers. So in the spring, we began tracking COVID-related complaints quite early on in March, and for the period between March to the end of June, we received over 560 COVID-related complaints, and almost half of the complaints that came into our office at that period of time were COVID-related. Since we opened in 2016, we've had a fairly small percentage of complaints that have been about long-term care. And in the spring, that completely changed. And we had an increase in complaints about long-term care of 370%. So our complaints began to mirror what we were seeing in the media at the time. You will recall that this would be around the time that the Canadian forces were coming into homes in Ontario and Quebec, and we were seeing that the severity of complaints that they were reporting on, we were also seeing in our office. These are the kinds of things that we were hearing about. So these are the three sectors that I mentioned earlier that we have jurisdiction over, and these are the issues that we were hearing about. And probably some of you who are joining us today may have been one of those complainants coming to our office. I'll go through them in order. So visitation, no surprise, one of our top complaints, and we're just having a staff discussion about this morning. We're seeing it again now that we're back into second wave and the restrictions are starting to be limiting again. So we're going to probably have the same issues. IPAC was very much about staff being concerned that they didn't have proper training and they didn't have expertise in the home, and so we're not sure how they were to be changing their care routines. Communication was very much complaints from family members who were not only were they not able to be in the building, but they were also having a very hard time understanding what the status of their family members' health and well-being was. So trying to get regular updates specific to their family member was difficult, and going to a home's website where there was just general information was not what people were really looking for. Quality of care, again, this was a lot of staff complaints about the concerns that they were having about residents' well-being and safety. Certainly, we had stories of people, not eating, getting dehydrated, getting sort of bed sores, not having proper bathing, and obviously mental health suffering enormously. Staffing was more around the lack of staff, so not feeling that there were enough people in the home. And early on, of course, there was also the issue of staff going between homes, which they did eventually put a stop to. Discharge and transfer was both people being discharged from hospital because they were trying to get the beds freed up to long-term care facilities that were in outbreak, which was of serious concern to both the patient and the family, but also the opposite, people who were positive going into hospital and families not being clear where they were. Testing was largely concerns around getting access to testing, particularly when at some point it was a requirement before you could do a visit, and not getting timely results in order to do the visit in time. Access was access to services. So this was more specific to hospitals than it was to long-term care homes. But in relation to long-term care homes, it meant things that might have been going on in the home, different programs and so on, non-medical services were stopped. PPE was lack of it. So again, concerns that there wasn't enough supply, and so workers were coming in without it. And delay, again, this was more hospital than it was long-term care home, but it was just, usually the delay was something, if you were at the top of the list to say to go into a home, that got delayed. So we also, besides hearing from family and from caregivers, as I was just mentioning earlier, we did hear from whistleblowers. So we had a number of staff working in long-term care homes who came to our office. It doesn't happen often, but it certainly was more so during COVID. And they shared quite serious concerns with us about the quality of care, but they were also quite worried about their inability to prevent outbreak. So even if they weren't in a home that had an outbreak, they were sort of convinced that it was going to happen. And many of them were very worried about losing their jobs because they came to us. Obviously, our stuff is confidential, but people were still concerned. So what we did at the beginning of this was we reorganized our internal processes so that we could handle this larger volume of complaints, and we reassigned our entire investigative team to focus on serious long-term care complaints related to COVID. All of the urgent ones were escalated directly to the home, meaning we called them and tried to work through what was going on. We also let the LHINs know for the regions that this was occurring in, as well as the public health units. We also notified both the Minister of Health and the Minister of Long-Term Care, as well as officials at Ontario Health, because we were one of the key organizations that was getting granular information on site from the actual sites themselves. There wasn't too many other people who were able to do that, so we wanted to make sure that senior officials knew something was dramatically wrong. And then we launched a public appeal for complaints to try to better understand the issues. And we made a number of, I think more than a dozen mandatory reports to the Ministry of Long-Term Care, which we're required to do. So it goes to the inspection branch. Following the public appeal, we then received another 150 and 98 homes, complaints about 90 homes that had outbreaks, but also 29 homes that did not. So outbreak was obviously a major concern, but there was still other things going on in other homes was also a bit troubling. So in June, then we announced our special our systemic investigation, and this is an authority that we have in our legislation that allows me to determine that something is systemic in nature and that we are not going to deal. I mean, we still deal with individual complaints, but we want to do more than just resolve individual complaints. So we launched our systemic investigation in June, and our general kind of process is we go through a planning process, we collect evidence, we have the right to subpoena documents, we do witness interviews, we analyze that evidence, we test the findings, and then we make recommendations. So this report that came out last week was very much focused on the complaint information. But this investigation report will be out sometime in 2021. And we will be dealing with a number of individual homes and doing interviews and them. So what we heard, again, just to remind you, IPAC, these are the big ones, IPAC, visitation, communication to families, quality of care for the residents, lack of staffing, discharge and transfer between hospitals, and lack of. So these are just vignettes that we heard that part of our job is to try to amplify your voice when you come to us. So in our report, we did describe a number of specific complainant concerns. This is one about a complainant who came who was very concerned about the IPAC or lack of it in her home. And she reported that her mother had not yet received the results of her COVID test, but she was moved into an area of the home with active COVID patients, to a safe area for healthy residents, and she was quite worried about what that was going to do to the other residents. Eventually, it turned out that she was in fact positive. So, she had exposed a number of residents in the home. And this one is a tough one. Essential visitor, the definitions of this, the directives changed over time. The terminology changed. Now, just recently, there's another one that's specific to certain geographic areas. So it's quite a complicated maze for families to try and figure out. And even when you think you understand the rules, the home does still have the ability to sort of apply them within their own circumstances. So sometimes even if you've got the directive in front of you, the home may not be honoring it for some reason. So it is very complicated. That the idea that you have to be tested and screened and book appointments and stand outside a window, we heard about all of that, as you can well imagine, and people were in great distress. Communication, as I mentioned earlier, very frustrating when you can't be in the building and then you can't get any information from the home about how your loved one is doing. This particular one was very sad. She learned that her mother was sick. She then was told after the fact that her mother had died, and she couldn't. She had no opportunity to say goodbye. So, you know, exceptions to visitation or compassionate grounds was not happening. And then our policy recommendations. So this will align with, you know, the buckets that we've just gone through. So we had 4 areas where we made specific recommendations. One, and I'll go through them in a bit more detail. The first was to look at contingency planning for every single home. We definitely wanted to see a change in the visitation approach. We wanted to see some dedicated resources for communication, and we want some whistleblower protection staff. So in terms of contingency planning, what we're talking about here is we want to make sure that every home has got a plan to deal with IPAC, to deal with staffing. So what happens if you start to have shortages? Do you have agencies that you can turn to? Are there volunteers that you can use? In some cases, some innovative homes actually went to the family members and said, we're going to hire you, and you're going to come in and we're going to train you. And the deal is you can look after your family member and another 2 or 3 residents, so that they didn't experience the kind of staffing shortages that others did. We want to make sure that there's transfer plans, so that if we do have somebody coming from hospital or somebody going to a hospital, there's a clear plan for that, and that there's communication to the family, and that all staff have up-to-date training regarding IPAC and PPE. And one of the things that we think that top line there that we say partner organizations is that we want to make sure that homes who don't feel like they have in-house expertise have a partner organization. It's probably going to be a hospital, but it could also be public health or others in the area. We want to make sure that they have access to that expertise. We recommended not restricting visitors entirely, even if it's a second wave and even if a home is in outbreak. I think we've all learned what that has done to residents' physical and mental health, but what it's also done to families' mental health, and that there are ways in which they can safely visit as long as it's based on good evidence. There's a risk assessment in terms of how risky the visitor actually is, and there must be exceptions on compassionate grounds. Understanding, of course, it has to be a somewhat limited number, but they still should be allowed in as long as the appropriate safety precautions are in place. We want to also make sure that this time around families are kept up to date, especially now that we're back to limiting in certain areas. Toronto, Ottawa, I think, are all now back to 1 person. So we want to make sure that the homes have got resources put to keeping families up to date. But the communication is just essential, and if it does require extra resource, then we sort of feel that that's an appropriate role for government. And then lastly, we do want to make sure that people are protected when they come to speak to us. There is a very limited protection in the Long-Term Care Act for people who participate in ministry inspections, but that is not us. So it doesn't extend to us, we don't believe. So we would like to see a more broad protection for healthcare workers to come forward, in good faith, especially during something like a pandemic, where there's hardly any other way to get information about what is happening. People shouldn't have to worry about reprisal in order to tell us what is happening. So we want to thank everybody who did come to speak with us, and we're still hearing COVID complaints from long-term care, so it's not over. I understand sometimes it's very difficult to come forward, or you don't feel like reliving your experience, but it's one of the things that we are here for. So if you have a complaint, we would really like to hear. Leave the number up there, and I'm happy to take some questions.
Sure. Well, I do want to thank you for the summary and review of the recommendations throughout the presentation. The first question is, why isn't there one essential visitor allowed per resident with guidelines?
Right. So I'm going to start with the visitation question first. So the patient ombudsman does not set those rules. I would be happy if we did, but we don't. So that guidance comes from public health and whatever the health command tables or the planning tables are deciding. I have to say we are like that. The view that expressed in that question would be mine as well. If there's appropriate precautions in place and staff are coming and going every day, I'm having a hard time understanding why at least one family member cannot. I think they've backed off a little bit from where they were in the spring, but it's still quite restrictive. And as of yesterday, now outings are prohibited in certain areas. So, I think there's lots of good guidance on this. There were some very strong reports in the spring from a number of organizations, including the Canadian Foundation for Healthcare Improvement, the Ontario Hospital Association, a group that Dr. Samir Sinha headed up. There are a number of documents that actually walk you through a checklist of what must be in place in order to have a family member visit on a regular basis, even in a home with an outbreak. So I cannot explain why that is not what we're doing here, but we made the recommendation not to go backwards, and we'll keep profiling that as best we can. The second question, I'm sorry, you were cutting out a little bit, Kathleen. I think you said something when somebody went in, they were very upset about the state of their family member.
Yes. So the shoes that they used to walk were worn, and then also the brakes on the walker that they used were worn. It probably relates to just understanding for staff to update families on what they're doing to make sure that things that they need to purchase or things that they need to provide support, I guess, outside of the home, mobility aids, like how could we improve communication, I guess, moving forward if there is a limitation in who can enter the homes?
Yeah, so again, that's part of our communication recommendation, that we really think the homes have to have dedicated resources. Literally, people need to be on the telephone calling family members regularly and letting them know what is required or what they need. The other thing that we did experience later in the summer, so this data is not captured in the stuff I just showed you because that's just to the end of June. But during the summer, we started to hear from family members who were able to go back into the home now, because over July, August, the restrictions were less. And the shock that they experienced when they finally saw often it was a parent, how much they had deteriorated was almost as frustrating as not being able to go in. So, if you are unaware that let's just say your mom isn't eating and has lost weight and is getting more confused, and you haven't seen her for 4 or 5 months, and you go in and you're expecting something different, it's pretty distressing for people. So again, that sort of regular updating communication is really a must.
So a question came in, and they aren't sure if you're allowed to share the specific details, but they wanted to know, for those homes that were able to actually bring family in and train them,
yes,
where were they located, or what were the names of those homes?
Okay, yeah, so that information was public. There was actually an article, the one that I was referring to, Kensington, which is here it's in Toronto, and the CEO, John Yip, wrote a personal account of what it was like to be working in the home then and what they were doing. I think it might have been in Toronto Life. It may even be on the Kensington Health website, but he was very innovative in the way in which he just did what he thought was right. And he got the families involved. And of course, everybody who was asked was happy to go in and provide some support. And if, they're looking after somebody else's family member as well, they were fine with it. And so they trained them and they went in. The other interesting place was, there was some interesting stuff in Kingston. where the, and as you may know, Kingston has, now that university's back, it's a little different, but at the beginning of COVID was one of the lowest public health units in terms of their case numbers. And what they did was they went to the city and said, you have restaurant, public health inspectors, restaurant inspectors who are trained in infection and hygiene, give them to us, long-term care homes, and we will train them to go into these homes, and then the families don't have to be walked. So there, there's definitely ways in which you can think about doing this in a safe way, but balancing it with people's access to their families. I mean, this notion that you say, sorry, you can't see your mother for 6 months is really, I think, quite cruel.
So how does your report relate to the work of the commission?
Yeah, good question. We've been getting that a lot. So we got started before the commission was actually established, well before. So, we didn't really know. I mean, there had been a commitment that the premier had made a commitment to be a commission, but we didn't really know what their terms of reference would be. So we got going. We have had a good meeting with Alison Drummond and her staff. We're very clear on not wanting to duplicate each other's work. We're very clear on not dropping reports at the same time. We want to make sure that we're coordinated. They are, at the moment, they're definitely trying to get a picture from as many people as they can. So we've seen, they've had associations come in, they've had public health folks, they've done briefings from the government, they've had, I believe the Residents Council have given impact statements. So they're gathering information, but their focus will be on, I think, more on government policy and system issues. Not that they're not interested in what happened to residents' experience, but they're going to have a sort of a broader umbrella, whereas our focus is very much what happened to residents, caregivers, and staff. So we're quite granular in that sense, whereas they may have more system policy recommendations. The other group that is also involved is the Ontario Ombudsman, which is a provincially appointed ombudsman that oversees all of government departments. They're doing something specific to the pandemic as well, but I think theirs is going to be a longer, probably a 2 to 3 year window, whereas the commission, I think, has an April deadline of next year, and we hope that our piece will be out next year as well. But I can assure you, all three organizations are in touch with each other, talking with each other, making sure that we're well aware that we're trying to have different, looking at it from different aspects. But I can see why it's confusing.
So this is from a family member who, when they answered the screening questions, they work in another facility, such as a hospital. So therefore, in the screening, they're not considered as an essential caregiver. So it's a bit of a challenge because they do want to take on that role. However, because of how it's written, it kind of excludes anyone who might be working in another long-term care facility or in a hospital. So is there anything that can be done to change that specific policy?
Well, so in that case, I don't know whether the policy is the government directive or it's the home itself. The government directive, I don't think we're able to change. Like I said, I'd love it if we could. We certainly can convey concerns to them, but they're going to do what they're going to do. The home is a slightly different question. So if it is specific to a specific home, and it's a specific individual, yes, if they called our office, we might be able to try to do some kind of mediation. It's very hard, from what we can tell, across the province, homes are dealing with it a little bit differently. It's not particularly consistent. And so what one home might do in one circumstance, another home might not. So certainly our frontline staff, the first thing they try to do is to try to resolve and mediate. So if somebody's having a problem with a specific home, please do call and we'll see what we can.
There's another question about visitation, specifically if the parent of a minor is living in long-term care, what can be done to allow that minor to be able to go in to visit their parent?
Yeah, same thing. It's going to take some kind of a negotiation with the administration of that home. And again, you can do it. Oh, there's Jason's got our number there up, and it's on the slide as well. That's our toll-free number. And we have frontline staff who take those calls, and what they'll do is they'll go through the situation. You have to provide consent in order for us to ask some questions, and then they'll go through your situation. We discuss it internally. We decide what maybe the first step is. We're going to call the home and see, negotiate something, depending on the willingness of the home to participate or not. And if we're not happy, we can then launch what is an actual investigation and undertake interviewing, and we make recommendations back to the home. In this case, pandemic, we tried to do a lot of stuff without going through a long process, the resolution, which it sounds like these visitation issues are as well. So the number's there, and please give us a call. And we also have bilingual French-speaking staff.
This one is, if a resident has a health issues that have been created due to the lack of staffing, what punitive action can the Patient Ombudsman's office take?
Well, we can't take punitive action. One thing I should make clear, our recommendations are not binding. So we make recommendations, but we do not have the ability to enforce them. So again, if there's a concern about lack of staffing, that would be a serious concern. We would go through a process with the home. We try to understand what reasonable steps did they take to solve this issue. It's why we recommended in this report that they have a staffing plan. Because I think what happened in the spring from what we've seen is that people weren't prepared. So nobody could foresee the sort of level of transmission as quickly as it was. We didn't know that much about the virus. We didn't really understand that it would be as severe as it was. And so you have to think about those workers who are being told to come in to a situation that is probably not that safe for them. They may or may not have, PPE. We had a one story in which the worker said, I told them I was positive and they told me to come in anyway. So lots of folks just quit. They didn't want to take that risk, having to choose between their income and their personal health. So staffing plans are key, and knowing who the agencies are in your local community that you could have reach out to and have a contract with if you need backup staff. Part of the issue too, as we well know, is that the PSWs, the personal support workers, who are by and large the majority of staff in long-term care homes, we don't have enough of them. We don't have enough of them. They're not particularly well paid. And until recently, they were having to do shift work in different homes in order to make income. So it's a group of people who've never been highly valued, who all of a sudden were expected to do really heroic work. So the staffing plan is really vital going forward, that we don't put people in that situation again. So there needs to be a plan, there needs to be PPE, and there needs to be training.
And this is a good question. I think you'll like this one. What is your take on the staffing challenge? Many staff are working long hours and homes say they're having difficulty hiring. So what's your perspective? What have you heard? What have you heard from multiple stakeholders about this topic?
I think that's very true. And so, that's why I think thinking creatively is where we need to go. Families, I believe, are willing to go in and help if there's appropriate precautions for them. And I don't know why that's not an option, because it is a somewhat of a solution to the staffing problem. They were there before doing lots of supporting tasks. In fact, if there's an outbreak, okay, so you have to put an additional layer of equipment and training in place, but why aren't you?
And I know that there are a few questions about PSW. So I know the Premier said that he was going to take an effort to try and get more PSWs. So do you know much about the PSW programs and training in Ontario, and if they're running at capacity with individuals who are going to be trained and ready to enter the field?
Yeah, no, I'm sorry, I don't know that. Yes, that has been a long-standing commitment from a number of governments. There's been issues around their pay grade. There's been issues around their training itself, whether it should be at a community college or keep some of the private colleges. So there's a bunch of workforce issues that have always been there with PSWs that have largely been ignored. And excuse me, the pandemic just highlighted it.
So how is the Patient Ombudsman's office dealing with homes that delay communication to the Ministry of Health, I guess, or Ministry of Long-Term Care of an event, as well as the family not being notified of that event that it occurred? So it occurred in March. However, it was not communicated to the family that it occurred until June.
Right. So everything we do has to be on the basis of a complaint. That's sort of the guts of our operation. I can't just decide, oh, there's an issue I think I'm interested in, I'm going to do something. You have to have it. So somebody has to come to us and say, I wasn't notified. And then we would go through our process with them that we talked about earlier. We would take the information, we would call the home, we would try to understand why you were not notified. We look for fairness, we look for reasonableness. It's not reasonable to not tell somebody once. So we would investigate that and make recommendations back. But as I say, we have to have a complaint in order to take something forward.
So someone asked a question about how the policies that were put in place for COVID differed from other outbreaks. So how is it that residents who smoke can go outside during an outbreak unsupervised to enjoy a cigarette, but those residents without this addiction cannot? That's just one example of rules that exist during traditional outbreaks.
I can't say for sure. My sense would be that in the spring, this landed quickly and we weren't prepared. We didn't know a lot, really around the world about the transmission of this virus. If you recall, early on, we were arguing about whether it was droplets or airborne or surface. We didn't even know. So I think there was real fear in the spring, and watching the mortality rates go up was quite frightening for people. And so it was lockdown. It was just lockdown, and we've never seen outbreaks on this scale before. So was it reasonable at the time? Maybe at the beginning. I think that the bigger question is as we got to know more about the disease, the virus, we also knew what we needed to do to end outbreaks. Why do we still have the rules that we had in the spring?
I think you raised a good point that long-term care does have policies that exist and hospitals that exist to deal with outbreaks. So it's interesting they just forgot that they had those. So this is a question about testing, and specifically testing for essential care partners who aren't given priority for testing because they aren't viewed as staff. And that's a requirement for them to be able to continue on in that role. So what advice do you have for that?
That is a conundrum. We were actually talking about that at staff this morning as well, because we're now hearing from people saying, I went to get my test 2 weeks before I'm supposed to be going in. I don't have my results back. And so I can't produce a result. So I can't, my visits get canceled. We're in something happening in the testing environment that I don't understand. They've moved to an appointment system now. So clearly the capacity is there, it's strained. So it's very, very confusing. And so, again, if somebody's not sure what the rules are, give us a call and we'll try to help you navigate through what you can do. And even having said that, and even having provincial directives, as I said earlier, the homes are still able to administer the policy as they see fit.
So this is a question about residents' possessions. So throughout the pandemic, if the staff of the long-term care home lose a resident's dentures or glasses or other appliances or devices that they need for activities of daily living, can the home be held financially responsible? Several members have said that this is something that happened during the pandemic.
Yeah. We actually had did a report on this. It was specific to a hospital. It was pre-pandemic, but that's exactly what happened. Dentures were lost and patient. So again, that is we would be calling up the home and saying, look, what's happening here? do you have some explanation as to how these things got lost? And we would work through some sort of resolution with the resident.
So this is a question where they'd like to know a little bit more about the Patient Ombudsman's office and your relationship with the Premier's office. So how are you making an impact? What is the role of communication between your office and the Premier's office? Also, if they call your office, does the concern go directly to the ministry as well?
Okay, so there's a whole bunch of stuff in that question. In terms of our office, so we are an independent office. We don't have a relationship with the Premier's office. We have jurisdiction over 3 parts of healthcare, so we do work with Ministry of Health officials, and certainly, as some of you probably know, Minister Christine Elliott was the Patient Ombudsman. She opened the office up in 2016, so she's quite familiar with our work. Like I said earlier, our recommendations are not binding, so what we do is we hear from people, we investigate, we try to shine a light on the issues, we produce public reports that put some pressure on those who are in decision-making roles. We try to provide real-time information, like I said, we did in the spring when we got something of concern that maybe they don't really understand how dire the circumstances were. We make sure that that information is provided to them. Sorry, there's one other part, there's a third part to that question. Something about communications.
Yeah, they wanted to know a little bit about how your office kind of engages in communication with the Minister of Health, Minister of Long-Term Care, and the Premier's office.
Okay. Right. Okay. So, I mean, we don't, I say we don't really have we don't communicate much with at all with the Premier's office. In terms of the ministers, the 2 of them, so we have what's called a protocol, I guess. So we share reports, give them a draft of the report before it's public. I do a briefing to make sure that they understand what the recommendations are, not because I'm interested in changing them. I'm not a fan of surprising people. So just to make sure that they understand what we are going to be saying. And we have at the staff level, so this is not the political side or myself, but at the staff level, the staff teams have fairly regular meetings just on the operations side, because our operation is actually, it is a publicly funded office. So our budget comes from the Ministry of Health.
And there are some questions about so for-profit long-term care homes that are spending their funds to upgrade business Wi-Fi. However, they're not upgrading the residents' Wi-Fi system, and it doesn't seem to be a priority. So the only means of contacting the resident is who can operate their home is through the home Skype account. What are some strategies or approaches, I guess, to improve accessibility of digital technology? Because it's obviously an important way for families to connect.
Yeah, and I think that sort of, we didn't get that specific in our communications recommendation because, we understand that the scale of homes is quite different across the province. Some big, some small, some chains, some independent, some nonprofit, some for-profit. But I think implicit in that is exactly that point, that particularly if we're going to be in a long-term environment in which visitation is severely restricted, then, what is the obligation to provide some technology in order that those who are able can communicate? I know a number of hospitals did do that. So they had iPads for patients in hospitals, but then they had foundations they could go to provide resource for that. So I think it is an important, conversation to have about what is the obligation then for the home to make sure that there's technology available for those who can.
There's a question about, so families are required to get tested regularly to be able to continue to go in and visit their loved ones. But testing for staff in long-term care is voluntary. So why is there a change in this?
I can't explain. No, I don't really think I can explain that one. I mean, that's what I was saying earlier, like some of this doesn't make a ton of sense. I mean, families are going about their daily lives, presumably being careful, as are staff. So why are the rules different? The thing that I guess I find kind of, the part I scratch my head over is understanding how much families do, like forget about pandemic for the moment, how much families do in a long-term care facility on a regular basis in terms of actual care. So not just the emotional and social support, but helping with feeding, bathing, mobility, exercise. And so when that's pulled away in the middle of a severe virus transmission and staff are getting sick, I can't add these parts up. So I guess we're encouraging sort of a rethink on that so that those tasks could come back with appropriate training, appropriate PPE, which would relieve the staff of some of it and also mean that there's going to be hopefully a better well-being for the residents. So I can't, what is that phrase? I can't square the circle.
Yeah. Families would like to know a little bit about who should they connect with or contact if they want to see a copy of the protocols that are in place for outbreaks.
The home itself should provide that. And if for some reason they aren't, again, I mean, a lot of them have it on a website, not everybody, but they should be able to at least give you that. And if they refuse, then you can give us a call.
And another family member says that they're concerned about staff workload and the effects on resident care and the absence of having even volunteers be able to enter into the homes and family members in the homes.
Yeah, no, it's a real concern. We know there are shortages. We know, as I was just saying, a lot of the care that was provided by families has been taken. You're not able to do it now because of the restriction on visitation, or at least certainly in some areas of the province. It is definitely a concern. I know that there's been a bunch of government announcements about more money coming. How quickly that gets translated into people, being available, I don't know.
Does your office know of any legal litigation happening directly related to no access for families?
Okay, so the only thing that we would have access to is what is public knowledge. If you're really a researcher here, and the class actions are filed, so you can see what the nature of the complaint is. Probably our in-house counsel has looked at all of those lawsuit claims. I have not, but I would imagine that the access is a huge part of it. So certainly, if you're interested in that information, it is publicly available.
My question is around what kind of advocacy we bring forward to the ministry to ensure that long-term care homes are first in line for getting the rapid testing.
Great. So I think that's a great topic. But as I say, our jurisdiction is based on complaints. So we would have to have a complaint that we would somehow use as a reason for conversation. Not to say that family councils in Ontario and lots of other organizations can't go and make that advocacy position well known. I certainly think it's something that the commission itself is very interested in. We know the rapid testing is coming, we just don't know when and how they're going to, as you say, make priority. I would hope that long-term care would be the top priority, given there's a separation of family members there.
Thank you.
Hi, thank you for the session. It was very, very informative. My concern is that I was at a nursing home that had a terrible outbreak at the beginning of April, and half the people died there. And my concern was that the long-term care inspectors weren't going in to do investigations. And even though we felt that there was a dire need for it, they didn't go in. And I guess my concern is with the second wave coming, I fear for all the other nursing homes. And, are there people that are going in on site? Like I thought at the beginning that the doctors were there, but actually they're virtual. So,
right.
So that's like, wow, that's a big thing. They're virtual. There are no long-term home inspectors going in, and I think that there is like a really life and death crisis, and I complain. They're like, well, they'll go through. Maybe we'll do a phone call. I think that's irresponsible.
Right. So the whole inspections process, as you probably know, was changed last year. So it used to be on-site, in person. It no longer is. So that's certainly an issue. The people who are going in are the staff, so the people who called us. That's why we're asking for whistleblower protection, so that they can continue to call us. And for those long-term care homes, which is now many of them, have a management agreement or a formal arrangement with hospitals. Hospitals were sending in their staff to do audits and to do training, and in some cases they were providing people. But the home has to voluntarily agree to do that, and not everybody did. So you make a very, very valid point. If there aren't, and the families aren't there either, so there aren't people coming in on a regular basis, whether there's a pandemic or not, it raises questions about quality.
Yeah, I think that, you know, there has to be more eyes on it, and
yeah, I totally agree.
And it's a systemic issue that needs to be raised and addressed.
Yeah, agreed.
Okay. I would like to ask a follow-up question to the last answer, which I thought was very good. You said that some nursing homes have entered into formal arrangements with, you know, local hospitals to
Yes.
get staffing support in the event of another outbreak.
Yes.
Is there a specific name of this agreement that I can use to specifically ask a long-term care home if they have such an agreement in place?
Yes. So there are different names, and I'm going to get them wrong. But what I will do is I will just check with my unless Jason Oliver, who's my communications person, I know is on here too. I don't know if he knows the answer to this, but I will check with our lawyer, because I know there's a bunch of different ones. One is actually called a management agreement, but I think there are other less formal ones. But we can certainly get that information, and I will send it back to Family Councils of Ontario, and then they could get it to you or post it to you. Or yeah, that's probably the easiest way to do this. I will get you the names, because yes, you can certainly ask and see if they have one, and that's one of the reasons why we recommended that they have a partner agreement, so that they're getting it in place before they have a problem, not in the middle of the crisis.
It has been the experience of this particular family council that unless the question is asked very specifically, the answer can be avoided.
Right.
So
Okay.
so I'd like a comprehensive, if I could, list of potential agreements. Thank you.
We will help for sure.
Thank you.
Hi, thank you. Thank you again as part of the process. I just wanted to make a comment on the last question about the agreement with local hospitals. I understand that there are two separate agreements. There is a voluntary management agreement whereby the long-term care home will enter into an agreement with their local hospital.
Right.
And then there is a mandatory management agreement, whereby the hospital goes in without their consent or without asking. Normally, the Ontario Health Team has a hospital in the team, and the long-term care home or homes use that hospital as a resource for IPAC, etc.
Right.
So that might be able to help the person that was asking the question beforehand. Okay, you're welcome, and thank you.
Now that we've reached 2 o'clock, it's time that we bring the webinar to a close. We'd like to extend our thanks and appreciation to Cathy Fooks and her team at the Patient Ombudsman's Office for providing us with this overview on their work and the information collected by their office on COVID-19. If there are any additional questions, please do not hesitate to reach out directly to the Patient Ombudsman or to our team at Family Councils Ontario.
Thank you. Bye, everybody.